anyhow, now we are in the pleural cavity. And I do this together with Professor Rückert, who is at the Charité, and he's responsible for the thoracic department, but because I do a lot of the surface malignancy, we do these cases together, and I'm proud to present something here. So just to start with an overview, of course, these are rare tumors. We talk about 2% of the chest tumors. Men have more diseases than women, and in Europe, or WHO estimates that this is asbestosis-related disease, and it accounts something about 100,000 deaths per year globally, so this is at least something. We have a long latency between exposure and disease, something about 20 to 25 years. And we think that in Germany, at least, we have the most patients coming in 2020 to 2050. We have then the most patients with pleural mesothelioma as well as peritoneal mesothelioma. And as you can see, in Europe, for Great Britain, France, and the Netherlands, something around 2 to 3 persons per 100,000 inhabitants. So it is rare. We have to know something about the pathology. It is a heterogeneous kind group of tumors. We have to know, the pathologist has us to tell something about the tissue invasion, so you have to ask him to figure out if there is something or not. We have to know something about the the EHC. It is recommended for the primary diagnosis of malignant pleural mesothelioma, and the pathologist has to do twice. He has to do the markers for mesothelial disease, and additionally to look if it is a mesothelioma or if it is adenocarcinoma. He also have to look for the markers of adenocarcinoma. And at the moment, but we have 3 main subtypes of the mesothelioma. This is the epithelioid, the biphasic, and the sarcomatoid subtype of mesothelioma, which is pleural as well as in the abdominal cavity. And the epithelioid is the better one. Sarcomatoid has a very bad prognosis. Coming to the staging, well, in the thoracic situation, you first have to know something about the history of the patients. You have to ask him, was there any exposure to asbestos? Then, of course, we have to perform a CT scan. MRI is coming at the moment. Literature forces MRI a little bit. PET-CT is in discussion if it helps or not. And then you have to have video-assisted thoracoscopy to get a biopsy of these disease. And I think what I wanted to press out now is that if you perform a biopsy, any kind, you have to, if you have the mesothelioma in mind, that could be mesothelioma. So please think about how to proceed if you have to perform an open operation after chemotherapy or after you know what it is. So you can just do with a pencil. You can know this is the scar, what I'm going to do for if I do further surgery, and then you just can put up a lesion here or here. So this is easy to cut out if you perform surgery, because we have a very high rate on implantation of tumor cells in the scars, and you have to remove this. And if you have scars here, puncture here, and puncture here, you usually can resect the whole thoracic ribs. So this is not good for the patient anyhow. And you also will evacuate the pleural fluid and have staging about other lymph node or other distant metastases. And perhaps you have circulating tumor markers, but at the end they are not very helpful because they are not specific. And so at the end we don't do it, we don't use them. We have a staging system for pleural mesothelioma, which means that you have a primary tumor which is limited to the parietal pleura, or it is involving the visceral pleura, or it is involvement of the diaphragm, visceral, or in the lungs, and so on. And just to make it here, you have the very good prognosis in local situation on the pleural, which easily can be removed with a pleurectomy. You have the situation that the disease gets up into the mediastinal situation, or as well as going up to the diaphragm, or bulky disease with lymph node metastasis, which you can see here, and even though the prognosis is getting worse. We know that the epithelioid mesothelioma has the best prognosis in these patients, and the worst is according to sarcomatoid type of pleural situation. And the TMN stage, as I just demonstrated, is not that prognostic value. So if you know that you have a stage 3 situation, this doesn't demonstrate you the real effect, more or less. And even though if you distribute to the histology, so epithelioid, biphasic, and sarcomatoid, you see according to the stage there's no significant difference. So at least you have to know the histological type and be aware to have a complete surgery. We will see what we can say there. So the first-line chemotherapy was proven for pleural mesothelioma is to combine cisplatinum with pemetrexate. If you combine this, you will have a much more response rate, 41% compared to 17%. So this combination seems to be very impressive in results. Also, the overall survival is significantly better than without pemetrexate. And if you combine these situations with bevacizumab, so at the moment these are the best results which you can achieve for pleural mesothelioma. But anyhow, just to summarize, cisplatin, pemetrexate, bevacizumab for chemotherapy, perhaps for induction chemotherapy in these kind of patients, can be a very good situation. We have new therapies in malignant pleural mesothelioma. They are going from anti-angiogenetic therapy with bevacizumab, what I just demonstrated to you. They come from mutation situation, from next generation sequencing, which is here. They have clinical trials on the way, and also for tumor suppressor genes where they have these pathways and have these kind of new drugs which they give. But very impressive and very promising are the immunotherapy treatment in mesothelioma with the PD-L1 antibodies. They seem to be quite impressive for results. And of course, you have other lines, what we are going for. I think this is future. But at the moment, we have to also to think about surgery. I think this is also very important to get these patients to surgery. together with other trials, as you can see here, if you put surgery in the treatment regimen of a patient with a malignant pleural mesothelioma, you see that we have significant better results if we can remove the tumor burden, but which is not in the sarcomatoid type. Therefore, we have to be careful to offer the patient surgery, even if it is an advanced situation. So we have to think if we do this. What possibilities and what kind of surgery do we deliver to the patients? So we have lots of possibilities. This is one from former times, I will say now. It is the extrapleural pneumonectomy, which means that you completely en bloc resect the pleura, the pneumonectomy, and the visceral pleura as well as the pericardium. This is so you just take everything out, even with the pericardium, nothing is left. But even though these kind of surgery are zero at the end, and you have the possibility you have to perform an extended pleurectomy or dissection, or only pleurectomy in several cases. So this is what we can offer at the moment. This was a case, I did this now 20 years ago, something like this, and I performed EPP, also an extrapleural pneumonectomy with the resection of the pericardium. We put then here a flap on it, but this patient, I must say, he survived, yes, and he lived 1 year, but he had a bad condition. So he was not able to take one stair. He was very much had a bad life quality of life. So I think this is not this is nothing which we should offer our patients. Extended pleurectomy means that you can dissect the pleura from the diaphragm, also from the thoracic situation, but you are not a zero at the end. But what you do, you leave the lung inside, and these patients have power to go, and they even though because they have no pleural effusion afterwards, so they have a better quality of life. And what you are doing is that you just dissect the pleural situation, and this is the lung. You also take the pleura of the lung. Sometimes it gets fistula, but they stop at 4 to 5 days. Hopefully, usually, but not in every patient, of course. And well, you have complications with this kind of surgery, even from the literature. They tell you about complications with the brain, vocal cord palsy, so you have to talk with your patient that this could happen to him. Arrhythmia or myocardial infarction, embolism, deep venous thrombosis, bleeding, bronchopleural fistula, air leaks. This is something what can happen to these patients, but we can see in what result we have. So the severe morbidity, if you compare this to this big surgery where you perform pneumonectomy compared to extended pleurectomy, you see the morbidity is nearly doubled or tripled in relation to extended pleurectomy. And just to see it here in the major postoperative morbidity, it is just in a multivariate analysis that you see sepsis and unexpected return to the operation room. It is always significant higher in the patient with extended pneumonectomy compared to pleurectomy. This is also seen in a multivariate analysis. So I think at the moment nothing is really pointing out that extended surgery in mesothelioma is the first thing you can do, but I think that the pleurectomy in combination with another treatment, with a hyperthermic intrathoracic chemotherapy, could be a good option to offer the patients. And we know that hyperthermia a long time ago always has a good influence on the treatment and the results. We learned from our ancients. And what we can see is that if you have a high degree of temperature, 42 to 41 degrees, we can induce the situation of heat stress-induced cell death, and especially if it is combined with chemotherapy. And we learned also that cisplatin serum concentration in the patient, if you have this kind of application, means that it is more or less local and is not systemically measurable. What we do in these patients after extended pleurectomy, we have cisplatinum in this kind of drug situation, or doxorubicin, and the duration is 60 minutes with a temperature in between 41 to 42 centigrade. And what we have to perform, we have to remove the scar from the further surgery, and then we put in the drainage, which the chemotherapy comes in and the chemotherapy comes out. So this one lays just beneath the scar, above the ribs, because there's always, you cannot shut these space. So this is the outcome, the outflow. And in this situation, we operated epithelial. He operated 55% epithelial and mixed carcinomas, and because he has a bigger kind of patient situation, you can see that if you have high TOC additionally to this kind of surgery, you have also better result for these kind of patients. And if it is epithelial cancer type, these are the results you can achieve. And I think for pleural mesothelioma, a median survival of 30 months is a good result, and they are usually in a good shape. So just to conclude, first, over the last 10 years, I think we have, there was for the mesothelioma no real new treatment options. We just have bad results for these kind of patients. At the moment, I think this will get the standard for treatment, cisplatin, pemetrexed, and I think bevacizumab will be the standard of care. In the future, I think we have to wait for new molecular mechanism, and they will identify new pharmacological targets. I guess we are on the way, and I think the PD-L1 or PD-1 antibody will be very promising. And conclusion 2 is more or less for the surgery. I think because of a very high morbidity of extended or extrapleural pneumonectomy, we will approach more or less the pleurectomy. And this is easy to perform. This will not be in a zero resection. I guess usually you will leave tumor in the mediastinal area, and you can do additionally high TOC to these patients. And even if you have a higher dose of cisplatin, these kind of additional treatment is feasible to do. Thank you very much.
У кого будут вопросы?
Any questions? Thank you so much for your presentation. I would like to ask you a question. Can we say that pleurectomy decortication can be contrasted compared to panpleurectomy? Sometimes you cannot perform pleurectomy decortication of a lung. Do you agree that it is not possible in some cases? And second question, have you met induced mesothelioma in young people after chemo? They treated lymphogrammatosis, and in 20 years they developed mesothelioma after they treated lymphogrammatosis.
But I agree it could be. Everything could be. Even if you treat young patients with some antineoplastic situation, always can something appear.
У кого еще есть вопросы?
More questions? What about two thoracotomies, two accesses? Do you use them in case of an expanded diaphragm? Two thoracotomies. Do you use?
It's necessary because you know that the pleural, the pleural space sometimes really went very deep, and in this situation, usually you have to remove the tumor, and this is possible. Yeah, but slowly, but possible. And from the lungs, as you said, sometimes this is difficult. You get fistula. Sometimes I take the scalpel, something like and then you can remove it. In some cases, sometimes you have to cut a little bit the situation, or a lobectomy at least. This is possible, but I must say from the experiences that this extended pleurectomy compared to pneumonectomy and extrapleural resection with diaphragma and all these things, it's a totally different kind of postoperative situation for the patient. So the patient, where you remove everything, he is really in a bad condition. He has really to do with his postoperative situation, and the others do really easily recover. So it is something else. And I think in this kind of disease, if you reach at least 24 months median overall survival and even more, this I think this is due to the good condition of the patient, because he can achieve an additional chemotherapy and he can reach possibly the new drugs, which are also quite good.
Спасибо.
Thank you.